Aruba's healthcare system is facing a timing problem. There is an urgent medical mandate to transition advanced end-of-life care into patients' homes, but the permanent law required to govern it, the Landsverordening Palliative Zorg Aruba, or LPZA, is still pending. Progress is frozen. Operating in this legislative void carries severe risks. Without formalized legal protections, deploying complex palliative care in a home environment exposes clinicians to heavy liability. For patients, the lack of a structured system leads to fragmented care, culminating in chaotic, crisis-driven trips to the emergency room. To navigate this reality, the Directie Olderenzaken and its partners developed the Practical Palliative Care Aruba Revision 2 Execution Guide. Looking at this structural layout, you can see the jump from the costly status quo on the left to the target home state on the right. To cross the legislative gap in the middle, the guide establishes a small, strictly controlled pilot program for 5 to 10 patients. It bypasses legislative delays by substituting missing laws with extreme, uncompromising operational rigidity. This operational bridge rests on 3 structural pillars: a 4-gate patient inclusion pathway, a protocol for extended-arm clinical delegation, and a dual-vector system for tracking success metrics. To protect the patient and the medical provider simultaneously, the healthcare system cannot rely on standard operating procedures. It must architect a specialized, highly defensive safety net entirely from first principles. This timeline illustrates the strict onboarding architecture. Candidates must clear 4 distinct operational gates. Gate 1 secures legal safeguards. Competent patients must sign a standardized bilingual consent form. For cognitive decline, the legally appointed representative signs, requiring immediate, official validation by the Directie Olderenzaken. Gate 2 aligns the medical triad via a binding shared care pact, signed by the primary physician and treating specialist. The general practitioner assumes 24/7 ultimate medical responsibility. The hospital specialist explicitly abdicates active intervention, shifting entirely into an advisory role. Gate 3 is the 168-hour matrix, requiring absolute bedside presence via a locked weekly roster of informal family, voluntary staff, and specialized nurses. But a roster isn't a safety plan. Gate 3 will not unlock until the Section 6 escalation protocol is physically attached. Gate 4 confirms the financial forfeit. Leveraging a special ministerial authorization, the AZV allocates a temporary micro-budget for each patient. This lump sum covers necessary disposables, medication pumps, and the professional night shift nursing required to keep the patient safely at home. Locking in legal consent, clinical hierarchies, bedside presence, and direct funding before a single medical act occurs, these 4 gates eliminate reactive, ad hoc care entirely. Even with the gates cleared, a primary clinical roadblock remains. The current medical practice law restricts advanced nursing acts in the home, such as programming and resetting morphine or midazolam infusion pumps. This schematic maps the pilot's extended execution workaround. Authority starts with the primary physician, flows through a nursing scope verification, empowers the on-site nurse, and terminates in a real-time digital log. This chain requires a highly detailed written mandate from the general practitioner. The protocol dictates the exact drug concentrations, baseline hourly infusion rates, and the strict mathematical boundaries for breakthrough bolus doses. To touch these execution units, Tier 3 nurses must pass a mandatory 2-day technical recalibration workshop. Furthermore, the protocol requires a co-signature from the Department of Public Health, the DVG, confirming that the specific delegation is legally permissible within the nursing scope. This graphic maps infusion rates against distress scores to illustrate the absolute scope boundary. It authorizes proportionate symptom titration only. Adjustments aim to relieve pain or dyspnea, stopping at a defined target score. Any indication for continuous deep sedation or any request for euthanasia falls completely outside this mandate. Refractory suffering requiring deep sedation triggers an entirely separate protocol requiring specialist sign-off. This strict written boundary is a political necessity, guaranteeing the palliative care pilot cannot be conflated with parallel euthanasia legislation currently under debate in Aruba. By operating within hyper-specific prescribing rules and unmistakable scope boundaries, The framework insulates both the nurse and the physician from criminal liability and political crossfire. Deploying opioids and midazolam in a home setting introduces the risk of diversion, requiring a flawless chain of custody from the pharmacy shelf to the patient's bedside. The logistics are strictly closed-loop. A single community pharmacy acts as the sole dispensing point per patient. Prescriptions are dispensed exclusively against the GP's written protocol, never on a verbal order. At the bedside, reconciliation is continuous. Dispensed medication is mathematically matched against administered volume in the digital pump log. Following a patient's passing, unused substances must be returned within exactly 48 hours, requiring a mandatory cosigner. If a delegated act fails or a substance discrepancy occurs, the pilot relies on a predetermined allocation of risk divided into 3 distinct tiers of liability. The GP carries clinical liability for the protocol design, the drug selection, and dosing thresholds. Meanwhile, the nurse's home care entity carries execution liability for the physical administration of the medication. However, there is a critical caveat to this protection. Execution liability only covers the nurse if the time-stamped digital log perfectly matches the GP's written instructions. This closed-loop system mathematically ties clinical accountability to real-time data. It leaves zero room for informal dose adjustments, ensuring every milligram is strictly tracked. This decision tree flowchart illustrates the pilot's predefined escalation protocol. A robust system must anticipate its own operational failure. Gate 3 requires this specific pathway to prevent chaotic emergency room visits. The protocol defines exact clinical triggers for escalation. If pain or respiratory distress scores exceed authorized thresholds for 2 consecutive assessments, or if an acute out-of-scope medical event occurs, the path activates. It also accounts for operational triggers. If a caregiver from the bedside roster becomes unavailable with less than 4 hours' notice, the home environment is officially compromised. To proactively monitor the family's endurance, the protocol mandates a bi-weekly caregiver burden index check-in. The pilot prioritizes maintaining the family structure. If the primary caregiver crosses a predefined exhaustion threshold twice, escalation is triggered. Once triggered, failure follows a rigid 3-step pathway. The on-call GP must respond within 30 minutes. If unresolved, Step 2 escalates to the hospital specialist. Step 3 is a structured readmission to the Horatio Odeber Hospital. Crucially, these readmissions utilize the patient's existing advanced care planning logs. The receiving hospital team is briefed using the home pump logs so that symptom management continues smoothly, rather than being restarted from zero. Defining the exact criteria and communication pathways for systemic failure serves as the ultimate safeguard against medical abandonment. This dual dashboard interface models the final evaluation phase. The Directee Oderenzaken will present 2 data vectors to the Council of Ministers. Vector A tracks clinical viability, maintaining patient comfort below critical intervention levels without inducing profound sedation. This vector also requires explicitly logging adherence to advanced care planning. It tracks direct matches between a patient's documented end-of-life wishes, like a do not intubate order, and the actual clinical path taken by the medical team. Vector B proves financial viability for the health insurance provider. The equation is exact. Net pilot savings equals the hospital bed days avoided, multiplied by the hospital's standard daily rate, minus the allocated pilot forfait budget. There is a critical rule governing this math. Any hospital readmission days during an escalation event are strictly excluded from the bed days avoided metric. This strict exclusion completely removes any financial incentive for the pilot to under-escalate a deteriorating patient simply to save money. Within 14 days of a patient's passing, a mandatory multidisciplinary review occurs between the GP, the home nurse, and the Directee Oderenzaken. This postmortem evaluates any operational friction and officially seals the final financial dossier. By combining exacting operational engineering, strict liability safeguards, and cross-institutional governance, the pilot establishes the definitive, stress-tested blueprint for Aruba's permanent legislation. Take a patient like MR. He is 74 years old, lives in San Nicolas, and has end-stage COPD. He fits a specific, highly prevalent profile in palliative care, the recurrent admission. His disease trajectory is punctuated by dyspnea crises, sudden, severe bouts of respiratory failure. Because there is no medical infrastructure in his living room equipped to handle these suffocating episodes, the only immediate option is to repeatedly admit him to the hospital ward. The pilot execution guide is designed to intercept this cycle. The objective is to build a hospital-grade safety net directly within a private residence, allowing high-acuity patients to stay home during terminal decline. But decentralizing acute care introduces immediate operational risks. Moving a highly vulnerable patient out of a monitored ward without a rigorous structure reliably results in fragmented clinical oversight, confused funding streams, and legal ambiguity for the practitioners. To safely transfer clinical risk to the home, the pilot guide relies on the 4-gate framework. It is a mandatory sequence of operational checks. The rule is absolute. No protocol can be executed until all 4 gates are cleared in order. For MR to even approach the first gate, he must meet the clinical intake criteria. Specifically, he is evaluated as willsbecom, meaning he has the cognitive capacity to understand and agree to the complex medical protocols that will follow. Moving a patient to home hospice requires informed consent, synchronized care teams, and legally binding oversight. It is a structural redistribution of institutional responsibility. Gate 1 establishes the legal baseline by aligning the medical triad. The patient, the general practitioner, and the hospital specialist review the terms of the pilot together. This alignment is codified through the Advanced Care Plan. For MR, this document explicitly records his directives: neat reanimaten, a do not resuscitate order, and a firm rejection of intubation. With directives set, Gate 2 requires the signing of the Shared Care Pact. This document serves as the legal instrument that formally transfers clinical risk from the hospital to the primary care network. The traditional hierarchy flips. The general practitioner steps into the center node, assuming 24/7 accountability. Conversely, the hospital pulmonologist shifts to a strictly advisory role, connected to the care network only by telephone for clearly defined escalation scenarios. To guarantee 24/7 accountability, the practice roster designates a specific backup GP at all times. The administrative burden is distributed, protecting the primary GP from systemic burnout. This GP-led model sharply contrasts with traditional palliative networks, where the hospital attempts to maintain remote control over a patient while dispatching disconnected community nurses. Centering the GP legally establishes a single, undisputed point of truth for clinical decision-making. It eliminates the care vacuum that frequently compromises home interventions. Gate 3 solves the raw logistics of decentralized monitoring. A week contains 168 hours. A high-acuity patient cannot be left unmonitored for a single one. This grid maps the 168-hour week. Tier 1 relies on family for daytime monitoring. Tier 2 volunteers cover afternoon slots to prevent exhaustion. Tier 3 nurses manage night shifts for complex pump checks. Finally, an administrative lock secures the file. Finally, Gate 4 authorizes the funding. The Machtigensbeslut document legally triggers the AZV pilot forfait, unlocking the specific financial reserves assigned to this protocol. Standard insurance models overlook the intensive requirements of home hospice. The pilot forfait directly covers the cost of the elastomeric pump, the associated disposable hardware, the required opioids, and specialized nursing hours. Hardware, labor, and medication are fully accounted for. Gate 4 verifies the clinical plan is financially solvent before the first dose is ever administered. Execution relies on a subcutaneous elastomeric pump delivering a controlled infusion. The GP writes a precise protocol dictating concentrations, baseline delivery rates, and bolus limits. This protocol permits breakthrough bolus titration, giving the nurse authority to deliver extra medication during a crisis. A DBG nursing scope authority must co-sign the document. Without this signature, the Tier 3 nurse cannot legally adjust the dosage. This dial tracks 2 clinical targets: driving the visual analog scale for pain below 4 and controlling the respiratory distress observation scale. But there is a firm scope boundary. The protocol explicitly excludes deep sedation and any attempt to hasten death. If family members struggle with the patient's decline and ask to end things faster, practitioners know how to respond. The GP must refer the family to the separate, independent euthanasia pathway. The pilot file itself must remain completely clean of any euthanasia reference. Mixing the 2 pathways jeopardizes the legal status of the palliative pilot. To prevent unauthorized deviation, the framework relies on a rigid chain of custody. Botica do Savigio acts as the sole dispensing pharmacy for MR's file. Every milliliter of dispensed medication is tracked directly to the digital time-stamped pump log version. Exact titration rules, secondary legal authorizations, and strict medication tracking build a reliable firewall. Strict adherence allows high-acuity interventions to safely exist outside of a regulated hospital ward. Even with strict controls, complex pathologies are volatile. On day 19 of the pilot, MR's respiratory distress scores repeatedly breach the protocol's safety threshold, despite the nurse administering an authorized breakthrough bolus. Looking at this graph of MR's clinical stability, we see the sudden spike. Section 5 of the protocol activates. Step 1. The on-call GP is reached within 15 minutes. They review the data, determining remote adjustments won't stabilize his breathing. Escalation moves to Step 2. The hospital pulmonologist is engaged by phone, reviews the assessment, and approves an immediate emergency readmission. Under Step 3, the hospital team is fully briefed before MR even arrives. They receive his digitized pump log and his advanced care plan outlining his directives. Receiving this specific data packet maintains absolute care continuity. The hospital staff knows exactly what chemical loads are in MR's system, preventing them from having to restart diagnostic and titration work from zero. The system accurately documents the failure. The escalation is formally logged as an incident in the pilot database, and to protect the integrity of the pilot's performance data, MR's hospital stay is explicitly excluded from the period's bed days avoided calculation. Back in the hospital, MR is stabilized over 3 days. Because his baseline directives and protocols are preserved, he is discharged and returns home under the exact same palliative framework. While the medical crisis is resolved, the systemic strain is tracked. The primary GP continues bi-weekly caregiver burden index check-ins with MR's daughter to monitor the psychological and physical fatigue of the family unit. During these check-ins, she reports moderate exhaustion. The system flags this data point, monitoring it against the 2 consecutive check-in threshold, which would trigger mandatory respite intervention if her condition deteriorates. Patients in terminal decline will face medical crises. The integrity of the 4-gate framework is measured by the safety, speed, and data continuity of the system's response to those crises, proving that rigorous decentralization works even when the underlying pathology escalates.